Welcome back. This is Ian Bodford.
And Liang Liu.
And this is the Clinical Correlation. Today's case is
a 36-year-old female presented for evaluation of a lump and redness to her chest for the last 3 weeks.
She reports over 1 month of right shoulder pain and 1 week of acute worsening redness and warmth to her chest.
She has a history of hepatitis C and IV methamphetamine use. She has been taking Flexeril and Tylenol 3 with no relief in pain.
Her vitals were normal, and this is what was seen on exam. She is noted to have swelling, induration, tenderness, and erythema over the right sternoclavicular joint.
Any other joint with that presentation, I would think septic arthritis or osteomyelitis. But how common is that in the sternoclavicular joint?
Definitely not that common. But a CT of the chest was performed and showed osteomyelitis of the medial end of the right clavicle and the anterior medial aspect of the right first rib.
The CT noted cellulitis and soft tissue thickening around the medial sternoclavicular joint, but no drainable collections.
Though sternoclavicular septic arthritis accounts for only 0.5 to 1% of septic arthritis in the general population, its prevalence increases to 17% in IV drug users.
A recent review of sternoclavicular or SC septic arthritis noted 180 case reports with a mean age of patients of 45 years. 73% of these patients were male.
Patients presented with chest pain 78% of the time, shoulder pain 24% of the time, and only 65% were febrile.
SC septic arthritis is typically insidious in onset, with symptoms on average noted to develop over 2 weeks.
Up to 62% of patients with SC joint infections have bacteremia, as opposed to 27% of patients with other types of septic arthritis.
Common risk factors include IV drug use, trauma, central vein catheterization, and predisposing conditions including diabetes mellitus, HIV, liver and kidney disease, and rheumatologic diseases.
Interestingly, there was no risk factor found in 23% of patients.
The SC joint capsule is reinforced by strong anterior and posterior ligaments and is not freely distensible. The absence of prominent joint effusions may contribute to the delay in presentation.
Due to this delay, infection is usually well established at the time of diagnosis with high likelihood of complications such as osteomyelitis, which is seen in 55% of patients with SC septic arthritis.
This infection can spread via local invasion and lymphatics to adjacent structures, resulting in serious and potentially life-threatening complications, including chest wall phlegmon or abscess formation, mediastinitis, superior vena cava syndrome, or septic shock.
Because of the rate of complications, a CT or MRI should be routinely obtained to assess for the presence of these complications.
The earliest findings on CT or MRI are an effusion, widening of the joint space, or mild cortical irregularity.
Needle aspiration of the joint is needed to tailor therapy, but is often unsuccessful due to the paucity of joint fluid.
If complications are present, in-block resection of the SC joint is indicated. Thoracic surgeons are the most familiar with this anatomy and are best equipped to avoid injury to the great vessels underlying the bony structures of the thoracic inlet. Staph
aureus is responsible for close to 50% of the cases and is the major cause of SC septic arthritis in IV drug users. As such, empiric antibiotic therapies such as oxacillin or cefazolin are needed to cover Staph aureus.
If the patient has risk factors for MRSA, such as IV drug use, hemodialysis, central venous access, or recent hospitalization, or if the local prevalence of MRSA is high, vancomycin should be given instead.
In the immunocompromised and patients with infected subclavian lines, empiric therapy should also cover gram-negatives. Cefepime or Zosyn are great options.
Specific antibiotics will need to be culture-driven and should be continued for 4 weeks in uncomplicated SC septic arthritis and for 6 weeks in cases complicated by osteomyelitis or mediastinitis.
And arthrocentesis is gold standard for diagnosis for septic arthritis and can help direct antibiotic therapy.
All synovial fluid analysis should include cell count with differential, gram stain, culture, glucose level, and crystal analysis.
Classically, joint fluid associated with septic arthritis appears cloudy or purulent, with glucose less than 60% of serum level and white count of greater than 50,000.
However, this cutoff is lower in the immune-compromised and in patients with prosthetic joints.
Gram stains are only positive about a third of the time.
To summarize, think sternoclavicular septic arthritis in the patient with local trauma, IV drug abuse, indwelling catheters, or the immune-compromised.
Not all patients will present with classic symptoms, so get the MRI or CT if SC septic arthritis is on the differential.
Depending on the patient characteristics, tailor antibiotics to cover MRSA, gram-negatives, and Pseudomonas.
Fortunately, our patient did well and was discharged after 1 week of admission with continued antibiotics.
Generally, when appropriately managed, the functional outcomes were almost always good, even in the case of SC joint resection, as the joint participates only modestly in upper extremity movements.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com.
And follow me on Twitter @MDNotified.
And me @EMLLou. Thanks for listening.